Hello and welcome to another teaching session for the MS and DNB General Surgery students. My name is Dr. Satish Agarwal. I am a pediatric surgeon and I am currently the chairman of pediatric surgery at Sir Gangaram Hospital in New Delhi. And today the focus of our teaching session would be to discuss some exam-oriented cases regarding hernia, hydrocele, and undescended testis, and then I'll be talking briefly about acute scrotum. So, inguinoscrotal swellings form a very important component of any pediatric surgical practice, and these include problems related to hernia, hydrocele, maldescent of testis, and acute scrotum. Now, it is important when I say inguinoscrotal, it is important to distinguish whether a given swelling is inguinal or scrotal or inguinal scrotal. So, this is an example of an inguinoscrotal swelling. You can see a bulge here in the groin as well as in the scrotum. Compare this to the other scrotum. Now, as compared to this, if you come here, this is a scrotal swelling. No inguinal component here. There is nothing there. Here again, there is an inguinoscrotal swelling. So, you can see a bulge in the groin and a big bulge in the scrotum. So, if it's a scrotal swelling alone, then this is likely to be a hydrocele. If it is inguinoscrotal, it could either be a hernia or an inguinoscrotal hydrocele. Now, the anatomical basis of all these inguinoscrotal swellings is related to testis, or rather related to the descent of the testis. If you remember your embryology, the testis in the intraembryonic period develops inside the abdominal cavity along the posterior abdominal wall along the mesonephric ridge. And from there, it descends down first inside the abdomen, then through the inguinal canal, and then into the scrotum. So the testis has three phases of descent. The abdominal descent from the position where it arises to the deep inguinal ring within the abdominal cavity along the posterior abdominal wall, and then through the inguinal canal it travels to come anteriorly and then exits the superficial ring, and then the final phase of descent into the scrotum. So, abdominal descent, inguinal descent, and scrotal descent. Now, as the testis comes down, and as you know that the abdominal cavity is covered by a peritoneal membrane, so when the testis exits the deep inguinal ring, it brings with itself a sleeve of the peritoneum like this. So, this is the peritoneum. The testis is immediately retroperitoneal, but it's merged with the peritoneum. So, when it comes down, it brings a sleeve of the peritoneum. And this sleeve of the peritoneum is called processus vaginalis. And then this sleeve gradually accompanies the testis all the way down to the scrotum, and then it obliterates. So, there is no lumen left in the processus vaginalis. With time, it just obliterates, and that's how the descent of the testis occurs. Now, what happens in hydroceles and hernias? In a hydrocele, the processus vaginalis has not obliterated completely. So, there is a minute way through which a little bit of fluid trickles down from the peritoneal cavity into the processus vaginalis, which enlarges and forms a swelling around the testis like here, and this is called a hydrocele. So in hydrocele, basically the processus vaginalis is patent, but the opening is small. Opening is small. It only allows some fluid to trickle down. Okay. While in a hernia, the pathology is the same. The processus vaginalis is the pathology, but the opening in the processus vaginalis is larger, and therefore it allows a piece of gut also to, so this red is the gut which comes down through this big defect, and this is hernia. So hernia is an enlarged processus vaginalis through which intestinal loops can herniate down and cause a hernia, and this is typically seen as an inguinoscrotal swelling. As you can see here, there is the bulge in the inguinal region and then the scrotum. Whether it reaches the scrotum or not depends on how large the sac is. If the sac is small, it's called as a bubonocele, and then it remains limited to the inguinal region. So if it's a swelling only in the inguinal region, which comes when the child is crying and disappears when the child is at rest, then it is likely to be a hernia, a small hernia, a bubonocele. Gradually with time, this sac will enlarge and will reach the scrotum also, and then it will become a truly inguinoscrotal swelling. So hydrocele, fluid, opening small, hernia, intestines or omentum, and opening is large. So hydrocele, to summarize, is a peritoneal fluid collection in the processus vaginalis, and there is diurnal variation in size. Why? The opening of the processus vaginalis in the hydrocele case is small, and it allows only a little bit of fluid to trickle down. But if you let the child lie down, the fluid will not slide back immediately. It's called as an inkwell effect. What is an inkwell effect? The fluid will come down gradually, but if you invert, if you hang the child upside down, it will not immediately recede back because the opening is so small. Therefore, it's called as inkwell effect. But when the child is sleeping during the night, we'll find that gradually the fluid will go back into the peritoneal cavity, very gradual process. And so when the child wakes up in the morning, the mother will notice, well, the swelling is much less. And then during the course of the day, when the child is active, running around, the fluid again trickles down and the swelling becomes big. So towards the evening, when the child has been active, the swelling is big. When the child wakes up in the morning after say 3 or 4 hours of sleep, the mother will feel that the swelling is a bit smaller in size, and this is typically seen in hydrocele. There is positive fluctuation and transillumination. I will show, because it is fluid, so it will be fluctuant, and there will be transillumination because it's a clear fluid and not blood. One more typical feature of the hydrocele is that it tends to resolve by itself in 1 to 2 years. If it is not causing any problem, if it's a lax hydrocele, then you can leave it alone for automatic obliteration of the processus vaginalis, and therefore the hydrocele will go away by itself. But if it doesn't resolve by 2 years, or if it is progressively enlarging, it's very tense, causing compression on the testis, then we need to operate on a hydrocele also. A typical feature of hydrocele swelling is that you can get above the swelling because it's a fluid collection in the tunica vaginalis. So it does not have a component of inguinoscrotal component, but you can go above the swelling, and therefore all the swelling can be below the limit of your finger. There is another variety called encysted hydrocele. Encysted hydrocele is a localized collection of fluid within the processus vaginalis, where the part of the processus vaginalis above the encystment and below the encystment are very narrow and therefore not discernible. So the fluid collects only in the part of the processus vaginalis, and therefore the testis below this will be eminently palpable, and then as you pull the testis down, the processus vaginalis will also be pulled down, and so will the swelling be pulled down, and therefore you can kind of do a traction test. If you put traction on the testis, the swelling will also come down. Just like in neck swellings, you have a thyroglossal cyst which moves with deglutition because of its typical facial attachments. As I mentioned, huge hydrocele can cause pressure atrophy of the testis because they will compress on the testicular vessels. Very rarely there can be abdominoscrotal hydroceles. They are rare, and in that situation hydroceles may extend into the retroperitoneum through the inguinal canal. They are rare, and therefore by and large, generally speaking, hydroceles will not have an inguinoscrotal component. Now this illustration is just to illustrate. So this is a scrotal swelling, and this is transillumination. For transillumination, you should dim the lights of the room, and that is when you will be able to clearly see a brilliantly transilluminant. Hydrocele is called as brilliantly transilluminant swelling. So again, I am reiterating, hydrocele is a fluid collection around the testis. It tends to resolve spontaneously in 1 year or maximum 2 years. Hernia contains intestines or omentum, and hernia can obstruct. Because it contains intestine can get obstructed, and hernia will require surgery soon. While in a hydrocele you can wait for 1 to 2 years, in a hernia you should not wait and you cannot wait. So let's talk about inguinal hernias. In children, inguinal hernias are almost always indirect inguinal hernias because their pathology is related to a patent processus vaginalis, which comes through the inguinal canal from the deep ring to the superficial ring and then to the scrotum. And inguinal hernia repair is one of the most common operations performed in pediatric surgery. This is the figure incidence, 0.8% to 4%, more higher incidence in preterm babies as high as 25%. And that is explained by the fact that the inguinal phase of the descent of testis is still going on before the final time to delivery comes. And if a child is born preterm, so that phase of testicular descent is still occurring, and therefore the child will be born with a patent processus vaginalis, and therefore there is always an increased chance of developing a hernia. The most common period during which the hernia develops is obviously the first year of life, and it peaks during the first few months of life. Right side is seen in about 60% of cases and bilateral in 10%. The figure of bilaterality is higher in girls. Now this is a laparoscopic view to show you the deep ring and its relations and the processus vaginalis. Now this view is the normal view, and you are looking at the deep ring, which is here. Deep ring is here. You are looking from the head end, you are inside the abdomen, and you are standing towards the head end of the patient. This is the left side. This is the remnant of the umbilical artery, also known as the medial umbilical ligament. And this structure that you are seeing is the vas deferens, which is emerging from the deep ring and going along this medial umbilical ligament and then going behind the bladder deep inside the pelvis. This is the testicular vessels, the cord, the testicular artery, the testicular veins, pampiniform plexus, etc. And this is the deep ring. And this structure that you are seeing is the inferior epigastric vessels. So inferior epigastric vessels form the medial boundary of the deep ring. This is the deep inguinal ring. Deep inguinal ring normally is closed because it has allowed the testicular vessel and the vas to go down, and this is the start point of the inguinal canal. Inguinal canal will then run like this in this direction. Now here in this illustration you can see that's the vas, inferior epigastric vessels, the testicular vessels, and this deep ring is open. And so the layer of the peritoneum enters the deep ring through a patent ring, and that is the sac, that peritoneal membrane which goes inside the inguinal canal forms the sac. And here again inferior epigastric vessels, and you can see some omentum going into the deep ring which is open. So this is a hernia which contains omentum. This is a hernia which is not containing anything. The intestine would have been there, but because this child is on a laparoscopic view, so intestines have reduced. But this is an open deep inguinal ring with vas and vessels entering, and there is a sac.